Drop it.
Hello everyone, welcome to Surgical Utopia and yet again another video on the cyst of jaw. Today we will be discussing about the periapical cyst, which is also known as dental cyst, and it is the most common odontogenic cyst. The cyst may develop rapidly from periapical granuloma and as a consequence of untreated chronic periapical periodontitis. There are various other names allotted to this cyst. The first one is the radicular cyst and the second is inflammatory cyst. So basically the cyst begins as asymptomatic and it progresses very slowly, but infection of the cyst causes swelling and pain to occur. Initially the cyst swells to round hard protrusion, but later on the body resorbs some of the cyst, leaving softer accumulation of fluid underneath the mucous membrane. The larger cyst may cause bone expansion or it may displace roots. Discoloration of the affected teeth may also occur, and patient will present a negative result to electric and ice test of the affected tooth, but will be sensitive to percussion. Moving forward to the mechanism of cyst development, there are three stages. The first one is the initial stage, then cyst developmental stage, and then cystic growth stage. In the initial stage, the epithelial cells from the rest of molasses at the apex of roots of a non-vital tooth become stimulated due to body's inflammatory response to bacterial endotoxins infecting the pulp or as a direct response to necrotic pulp tissue and therefore re-entering the growth phase. The byproducts of the bacterial growth then are able to seep into the periapical region through the infected pulp. The epithelial rests from the strands are attracted to the area which contains exposed connective tissue and foreign body substances, and several strands from each rest converge and surrounds the abscess or foreign body, following which the fluid flows into the cavity where the forming cyst is growing due to increased osmolality of the cavity in relation to the surrounding serum in capillaries, and the pressure and the size of the cyst increases. There are various theories associated with the mechanism of cystic growth. The first one is biomechanical theory. According to this, the pressure and concentration differences between the cystic cavity and the growth surrounding influence the fluid movement into the cyst, causing the size increase. The second one is biochemical theory. According to this, the collagenase activity in the jaw bone leads to bone degeneration, providing room for the cyst to develop, and the substances released by the body's immune system as a result of the connective tissue breakdown, such as cytokines and growth factors, contribute to mobilization and proliferation of epithelial cells in the areas. Bone resorption is caused by substances such as prostaglandin 2 and interleukin 1, which are both produced by the cyst itself. This third theory is nutritional deficiency theory, which states that epithelial cells will form a mass inside the cavity and the innermost cells becomes deprived of nutrients because they are far from the source of nutrients, that is the blood vessels, which leads to degeneration of the innermost cells, and therefore it forms an aggregate of dead tissue, which further undergoes ischemic liquefactive necrosis and creates the cavity space surrounded by growing epithelial cells. The fourth theory is the abscess theory, according to which the epithelial cells have an inherent quality to reproduce and cover any connective tissue that is not already lined with epithelia. Formation of abscess must precede the epithelial proliferation in order for the cells to carry out this tendency. Now let's discuss how the diagnosis of radicular cyst or periapical cyst is made. Intraorally, the anatomical structures should be palpated to identify the presence of bone expansion or displacement of the roots and tooth. along with the presence of crepitus. Bulging of the buccal and lingual cortical plates should be seen. Radiologically, the cyst is confirmed by the presence of circular or ovoid radiolucency surrounding the root tip of approximately 1 to 1.5 cm in diameter. The border of the cyst is seen as narrow opaque margins which are contiguous with lamina dura. The periapical cyst has characteristic unilocular shape on radiographs, and there is also a severe border of cortication between the cyst and the surrounding bone. Then histopathologically, under microscope, stratified squamous epithelium of variable thickness is seen. Then a fibrous capsule of various thickness with chronic inflammatory cells will be seen. Russian hyaline bodies, which are amorphic eosinophilic linear to crescent shaped bodies in the cystic epithelium, is present in 10% of periapical cyst. Scattered ciliated cells are seen and cholesterol clefts in the cystic lining are present. Coming to the treatment of periapical cyst, the infected tissue of the periapical cyst must be entirely removed along with the epithelium of the cystic wall. The surgical options include the cystectomy and cystostomy. The cystectomy is the removal of a cyst followed by mucosa and wound closure to reduce chances of cyst regeneration, whereas cystostomy is recommended for larger cysts that comprises important adjacent anatomy. The cyst is tamponated to allow for the cystic content to escape the bone, and over time the cyst decreases in size and bone regenerates in the cavity space. Marsupialization can also be performed, which involves suturing the edges of the gingiva surrounding the cyst to remain open. The cyst drains its contents and heal without being prematurely closed. The differential diagnosis of periapical cyst is granuloma. If radiographically the lesion is large, it is most likely to be considered as cyst. The periapical cyst comprises of 75% of the cyst in the oral region, and the male to female ratio is 3:2. There are three types of periapical cyst. The apical type, which is seen in 70% of the cases, in which the cyst is present at the apex of the root. Lateral type, which is seen in 20% of cases, the cyst is present on the lateral aspect of the root, and the residual cyst seen in 10% of the cases, where the cyst reoccurs after being formally removed. So that's all for periapical or radicular cyst for now. I'll see you in the next video.